pela primeira vez em alguns anos, o tratamento é diferente dependendo do local onde a pessoa vive. Nós estávamos acostumados que um PEG ribavirina era igual para todo mundo. Agora, a Europa e Estados Unidos já faz alguns meses que não usam mais interferon. E nós ainda usamos interferon. E eles já têm a segunda onda e já um pé na terceira onda, e nós ainda estamos um pouco mais atrasados. Eu acho que no Brasil vai chegar, talvez os medicamentos vão chegar, não juntos, mas a gente gostaria que chegasse todos, sofosbuvir, cimeprevir, todos ao mesmo tempo. Mas se chegar o sofosbuvir primeiro, e a gente ficar por um tempo só com o sofosbuvir, antes de chegar ao cimeprevir, o que eu gostaria de perguntar, se imagine se vocês estivessem num ambiente em que só tivesse o sofosbuvir como nova droga, né, como fariam para tratar um paciente não respondedor a interferon ou intolerante a interferon, um genótipo 1? Se usariam sofosbuvir com ribavirina por 24 semanas, ou se fariam alguma coisa criativa, como juntar o sofosbuvir com telaprevir ou boceprevir, fazendo um cosmos brasileiro.
Hugo, now, today, treatment is very effective. Treatment is safe, and we can cure 100% of our patients. So this is terrible, because this is so effective, I don't know what will be the future of a pathologist. But anyway, this is a satisfaction. And I would say this is not a problem of efficacy, this is not a problem of safety. We have excellent combinations. We have to use one nucleotide inhibitor, polymerase inhibitor. We have to use in combination with one NS5A inhibitor or one protease inhibitor, and the two drugs are 100% efficient in most of patients. Even in cirrhosis, maybe we need a longer duration. I agree with you. I agree with you. 12 weeks, even less for non-cirrhotic patients, and maybe 24 weeks for F3, F4 patients. The problem now is not anymore the efficacy and the safety. The problem is the cost. How many patients we can treat in countries like France? France is rich, you know, very rich. No, I'm joking. I think we have less and less euros. For Brazil, for many countries, you know, there is gradient, interestingly. Most of patients with hepatitis C are in developed countries, less in, I would say, in countries with a lot of money. So the challenge within the future will be how to eradicate HCV infection in countries who do not have the resources to treat the patients. I think to Egypt. I think so. What is interesting, I will say today, this is so simple. You do not need to check the genotype. You do not need to check the viral load. You do not check IL-28 and all these things, because the treatment is pangenotypic, is effective in all genotypes if you use a good combination. The problem now will be access to therapy. How to screen? Most of patients, probably I would say 50, 60, 70% of patients are not diagnosed. And what could be the access, early access to treatment to eradicate infection?
So, Hugo, I think if I am not mistaken, you asked a specific question. So you have non-responders, and you're going to get sofosbuvir. So how are you going to use sofosbuvir in non-responders? So you're going to have two types of non-responders. You're going to have pegnefion and ribavirin non-responders, and we're going to have pegnefion, ribavirin, telaprevir, or boceprevir non-responders. So let's take each of these, and let's forget about the severity of disease. So let's say everyone's eligible. So if it was pegnefion and ribavirin non-responders, and you had sofosbuvir available, you would like to see data, but there's no data on 12 weeks with the non-responders. So there is recommendation of sofosbuvir and ribavirin for 24 weeks, but that's expensive. So I like this thought about sofosbuvir and telaprevir, which is a protease inhibitor and NS5B nucleotide polymerase inhibitor. In fact, Vertex started the trial. Of course, they're now out of business. I'm not sure where the data is with that, but it would be a nice approach to explore to see as to what kind of response you would get with those two drugs, with or without ribavirin. Now, the bigger challenge is you probably have a fair number of genotype 1 telaprevir and boceprevir exposed patients, and what do you do? So if you look at the ASSLD guideline, without any data, they recommended sofosbuvir regimen with interferon ribavirin or with just ribavirin. And I have a problem with that, without data to expose these patients to these expensive drugs. So I think we would want to wait. In 6 months, you're going to have decladisvir. And decladisvir and sofosbuvir works based on the publication of Mark and all earlier this year. And then hopefully ledipesvir will become available, and based on ION-2 data, you can use ledipesvir and sofosbuvir. So I don't think I would want to rush into using sofosbuvir, peg, and ribavirin. At least I have not used it. I have used cimeprevir and sofosbuvir only if they do not have baseline resistance to a protease inhibitor. But again, we'll have to see that. The baseline resistance testing is on population sequencing. There is a challenge with that. But in patients with advanced cirrhosis who fail protease inhibitor-based therapy, I'm using that. Now, the greater advantage for sofosbuvir and ribavirin will be in genotypes 2 and 3 non-responders to PEG and ribavirin. And in Brazil, there are a lot of genotype 3 patients. So if you had genotype 3 patients who fail PEG and ribavirin, I'd be inclined to use PEG, ribavirin, and sofosbuvir for 12 weeks in genotype 3 patients. And you can get the great value for your money there. So I think that's the way I see it.
Ok. Alguma pergunta da plateia antes que eu possa... Professor Esteban.
Just a very brief comment on the question you put. So the association between telaprevir and sofosbuvir. Janssen is licensing cimeprevir in many countries in Europe at the same price that telaprevir got. So in that sense, it is very easy to substitute telaprevir for cimeprevir. And you have one pill a day, much better tolerated without anemia, and there's the less expensive combination with sofosbuvir you can get up to now. And I think that it is very easy to achieve it in Brazil, because Janssen will do it, will substitute telaprevir for cimeprevir.
Eu gostaria de fazer uma pergunta. I'd like to ask you both a question regarding HIV co-infected patients. We are saying right now that the results for this population is quite the same as mono-infected patients. I would like to hear your opinion about that, because we are including in the trials patients with very good conditions for HIV. And in real life, things may be a little bit different. And the first question is that, how do you see that? And second question is regarding how to prioritize this population. We're saying that we have to treat mainly F3 and F4 patients. Do you think that we could have F2 included to prioritize access to treatment if it's an HIV patient?
Well, that's a very important question about a HIV co-infected patient. There are several aspects of HIV that are very relevant to hepatitis C. One is you have a higher rate of hepatitis C viremia, more rapid disease, and then with DAs, there is concern about drug-drug interactions. Sort of very interesting, I find that EASL has said that HIV co-infected population is no longer a special population. I personally feel it's still a special population because there are unique challenges in that population. Do you know how many combinations of drugs that are approved or used for HIV infection? I came to know recently there are about 88 combinations of drugs that are being used for HIV treatment. So I, as a hepatologist, would not know what antiretroviral regimen one has to use when you're using therapy for hepatitis C, because the studies were done in with limited number of combinations of HIV treatment. Regardless, based on the photon study which is just online in JAMA, you'll notice that these patients have done very well with sofosbuvir and ribavirin. So this is a population which certainly can benefit with sofosbuvir and ribavirin. They had both treatment-naive and treatment-experienced patients, and certainly this population could be prioritized. And given that they have more rapid progression of disease, even F2 patients would be kind of candidates for soft and ribavirin-based regimen in co-infected patients.
Probably this is interesting because probably between the SLD guidelines and the EASL guidelines there is some different feeling about the HIV, HCV infected patients. Outside of the guidelines are something important, but also the experience, the clinical experience is important. In my experience, probably the populations are different in different countries, so it's difficult to have a general point of view, universal point of view. In my experience, because we work with the major, in my university, the major Center for HIV co-infected patients, what we see first is contrary to what we observed 20 years ago, now the HIV co-infected patients do very well in terms of liver disease. It was not the case before. There was a high incidence of decompensation, of cancer and liver transplantation, but now I think now they have a good immune control. These HIV, HCV co-infected patients do very well, and I think are very close now to the HCV mono-infected patients. So I think if they are controlled for the immune system, their liver disease can be mild or moderate. This is the first point. The second point is when you look at the results of the studies with direct antivirals, of course these patients were not very well responding to interferon. But now with the new treatments, as you said, Raj, I think now it works very well. Indications are the same. Treatment is the same. And SVR data cure is the same rate, is about 80 to 90% in non-cirrhotic patients. So I would say these patients, this is my point of view, maybe not clearly stated in the guidelines. My point of view as a clinician is same indications, same assessment, same treatment in the HIV patients, and drug-to-drug interaction is not such a problem. Do you agree?
The problem, I would agree with most of what you said. In terms of drug-drug interactions, as I pointed out, select combinations have been allowed in the clinical trials. And as I pointed out, there are multiple combinations of HIV regimens. And it would at least be important to try and get a sense about the HIV regimen from someone who knows HIV better than I do before I start treating their hepatitis C.
Okay, thank you very much. Well, we have to interrupt now and call for the next... vamos começar, Eymar, professor Eymar, para a próxima sessão.